So next up, we have the whole team for the Stand Up to Cancer project. The Stanford team, which is comprised of, I'll lead off with everyone first, and then I'll turn it over to the team. Alice Fan, Assistant Professor of Medicine. Harmeet Bedi, Clinical Assistant Professor of Medicine, and Ophir Vermesh, a resident in radiology. So really excited to hear about this update, and I'll turn it over to you.
Great, thank you. I'll go ahead and share my slides. There we go. So it's really an honor to present to you today our portion of the Stand Up to Cancer grant. It's one of the dream teams. It's called the In Time Dream Team, which is the Intercept Lung Cancer Through Immune Imaging and Molecular Evaluation. The Stanford team is what we're presenting to you today, and it's led by Dr. Apparici. I'm going to just give you a few slides of overview about the bigger team, and then I'll go into a little bit of the clinical trial, but Ophir is the one that's going to give you the data from our imaging study. So it's really a tremendous team across multiple institutions. The PIs are Avi Spira at BU, as well as Steve Duminette in UCLA. And there are multiple institutions on the West Coast and the East Coast and even in England. And here at Stanford, we're really excited to be a part of it. It was initially Sam, that was our PI, and of course we miss him every day. And we carry on what he started here. And the goal of the overall DREAM team is to help address unmet needs and clinical needs for lung cancer. And if you think about the path that a cancer takes from the first molecular abnormalities in the first few cells until it's detected and then treated, there are several stages in lung cancer where we can really hope to intervene and change the trajectories of these tumors. So one question is, we don't know which patients with pre-malignant lesions will actually progress to invasive cancer. And so for these patients, we want to be able to understand the biology and intervene before they progress, and perhaps even identify targets for prevention. This is where we're going to focus today, which is if a patient actually has an indeterminate lung nodule, we don't know if it's cancer necessarily, and sometimes we just have to follow them over time. But it would be much better for the patients if we could figure out which patients never need to undergo that invasive diagnostic workup. And that's the focus of what we'll be talking about today. And then lastly, in early stage lung cancer patients, there's a subset who always recur despite surgical resection. And these are the patients that we need to be able to know when to intervene to prevent the progression to advanced disease. So the three aims are to identify prognostic biomarkers of pre-malignant lesions and build a pre-cancer genome atlas to identify new targets. We're focusing on aim 2, which is to develop diagnostic biomarkers in patients with indeterminate pulmonary nodules and eventually be able to predict tumor recurrence. And then aim 3 is actually developing companion diagnostics in ongoing clinical trials to understand who really benefits from adjuvant treatment. I'm just going to skip these slides because they are backup slides. Harmeet just texted me he's at a bedside emergency, unfortunately, so I'm going to go ahead and present his 2 slides. So the clinical trial that we're going to talk about today as part of the In Time Stand Up to Cancer Dream Team is our FSPG PET biomarker study. And this is a study that we began enrolling in 2019 to study this novel imaging, a glutamate imaging agent, and its ability to detect cancer in an indeterminate pulmonary nodule. The target goal is to accrue 50 patients over 4 years. And the inclusion criteria are simply that they have to have a pulmonary nodule that's indeterminate. They're age greater than 45 years or equal to 45 years. They're a current or former smoker with a significant PAC year history greater than 20 years. And patients are excluded if we already know that they have lung cancer, if they've had another cancer within 5 years, if they're pregnant or nursing. And we've actually enrolled 12 out of the 50 subjects so far, and 12 have completed all the required study procedures. 2 are getting ready to actually have their first imaging. So this is the status of each of the 12 patients. And some of them, as you can see, subsequently were found to have adenocarcinoma or squamous cell, and others continue to be under surveillance. So at this point, I'm going to turn it over to Ophir to show you some of the data.
So, so basically, as Alice was saying, we're really interested in figuring out whether, indeterminate nodules, lung nodules, actually end up becoming, more benign, or whether they stay benign, or whether they actually end up being malignant, and being able to sort of predict this in advance. And so, the reason that we're very interested in this is because every year, over 150,000 patients present to doctors with these, indeterminate lung nodules. And there's a variety of different definitions for them. We're looking at nodules anywhere in the area between 7 millimeters and 30 millimeters. But basically, most pulmonary nodules, when you first discover them on X-ray or CT, are indeterminate, unless there's biopsy confirmation, or there's been demonstration of 2-year stability, or there's characteristic benign findings on imaging. And also, most nodules that are below 6 millimeters are usually benign. Basically, we basically do FDG PET on nodules that are greater than 8 to 10 millimeters and have a low to moderate probability of a pretest probability of being malignant. And we do FDG PET with the idea, with knowing that there's often the issue of specificity. In other words, sometimes you can have false positives with FDG PET because infections can light up. There's also false negatives because sometimes you have things that don't light up that end up being malignant as well. And you also have high background in many tissues. So right now, the most useful, the way that we most often decide on whether something's going to be malignant or benign is kind of a based on morphology and how it evolves over time. Is it stable over time? And so to kind of overcome some of the limitations of FDG and in looking for better tracers that are potentially more predictive, we've been looking at tracers that have been developed preclinically that have shown some promise in a wide range of tumors. And one of them is FSPG. And FSPG is basically a glutamate analog. And the way that it works is basically glutamate is involved in energy production in cancer cells. So in the same way that cancers take up glucose, because they're very carbon, carbon is in very high demand in cancers. And so they'll look for alternative energy sources as well. And glutamine is one of them. And basically glutamine, becomes glutamate in the cell, or gets converted to glutamate in the cell, and then can participate in the TCA cycle, much the same way that glucose can. But usually cancers are in a hypoxic environment, and so the TCA cycle is, and so not a lot of the glucose is going to the TCA cycle. So this would be basically a supplement of that energy. The way that glutamine enters the cell is through this XCT transporter, and basically that's the transporter that we're using with this tracer, which is basically a glutamate analog. And so we're basically monitoring essentially the activity of this particular transporter that's revved up in fast-growing cells. And so FSPG has been used in a number of different cancers preclinically, and clinically. And clinically, it's been used. There's been clinical trials in prostate cancer, in glioblastoma, lung cancers, head and neck cancers. And where it's done very well actually are in cancers where, the background levels are low. And so one of the advantages of FSPG over FDG is, for example, in brain, where FDG has a very high signal, FSPG where FDG has very high background, FSPG has very low background, and so that's advantageous. Also in head and neck cancers, that's true as well. And so we were interested in seeing how FSPG does, not just in known lung cancers, which has been investigated in the past, but in terms of predicting the potential, the malignant potential of indeterminate nodules. And so in this study, we, as Alice mentioned, we were looking at a number of different, parameters, both clinical and radiological parameters for the various patients. And these are basically the parameters that go into deciding the pretest probability for malignancy. And so, there's been models like the Mayo Clinic model, the VA model, that basically look at, factors such as age, smoking status, the, whether there's been other cancers in the past, greater than 5 years ago, and as also, looks at, what is the shape of the cancer? Is it spiculated? Does it have, is it more in the upper lobes as opposed to somewhere else? And based on all of these criteria, it can you can calculate a pretest probability. And then FDG PET can kind of help you to get a sort of post-test probability. And so, one of the things that we're going to eventually look at is, can FSPG do that as well? And can it do it better? And do we even, could it also replace some of these parameters in terms of predicting? And so this is one of our patients, and you can see here the pulmonary nodule in the upper left upper lobe on CT. And so, this patient underwent FDG PET, and we can see it lighting up very well. And also you could see it lighting up on FSPG. And we basically, try and figure out then what is the intensity. And based on the intensity, usually there's a correlation between intensity and, how aggressive or the grade of a tumor. And so here we we're kind of looking at the relative intensities, or SUV max, we call it, between FDG and FSPG. And in general, we noticed that FDG has a higher intensity than FSPG overall. But that doesn't necessarily mean that FSPG is inferior to FDG. As I'll show you in a moment, we actually calculated accuracy profiles for both, and they were actually equivalent. One of the things we also looked at is gating. We do respiratory gating because due to the motion from breathing, there's a lot of blur potentially, and so that can actually average or kind of reduce your SUV max. And we just wanted to see whether with gating versus non-gated PET for FSPG, do you get actually a difference in your SUV max? And we actually didn't see a statistically significant difference. What was interesting to see was that when we separated out the cohorts in terms of higher grade, so in one cohort we had the patients who had cancer. In the other cohort, we had patients who are either benign or had slow-growing tumors that are under surveillance or are well differentiated. And so you could definitely see a big difference both for FDG and FSPG. That's statistically significant between those two groups. And when you look at the sensitivity is actually quite good for FSPG. There's a very small number of patients still, and we were able to detect, one of the lesions by FSPG that we couldn't detect by FDG. But again, it's still a small number of patients, and so it's too hard to say whether, FSPG would perform that well in a higher powered study. And with more patients, we would actually also be able to get more reliable data for specificity, positive predictive value, and negative predictive value. And so basically, in the future, we could also be looking at other next generation FSPG or glutamate analogs. This is an example of one particular tracer that was developed by Corinne Baynet in Sam Gambier's lab. And also that, I know also a few other people helped with this as well, but basically you get, higher uptake in tumors by this glutamate analog as opposed to the first generation FSPG. And interestingly, you also get lower uptake by immune cells. So hopefully that should also decrease your false positives in the future, where sometimes we get very high false positives from infection. And so that might be, one of the workarounds for that. And so with that, I'd like to acknowledge Sam, who I was a postdoc in his lab, and he, did a lot of the early preclinical work with FSPG is, with Eric Mitra in the clinic. I also would like to thank the people who preclinically helped develop FSPG in the lab, including Corinne and Meerweiss. And of course, the SUTC team, the Stanford Nuclear Medicine faculty who helped to read out the study, and of course the patients. And I'll open it up to any questions.
Excellent. Thanks so much, everyone. Ophir, Alice, and I think I see Harmeet is on as well. Yeah, I think it might be helpful if one of you is able to kind of mention how this fits into kind of the overarching study, because Stanford being one arm of the overall project.
That's right. So yeah, I can jump in. And so the slides that I quickly skipped over demonstrate really how this integrates into studies on over 1,000 different patients, actually. And so some of the groups are doing very deep sequencing at the single cell level from nasal swabs as well as tumor specimens to really understand how things change over time in the patients. And so every patient that's on this study is also getting a nasal swab for the sequencing as part of this effort. And we're hoping that this novel imaging with FSPG can help be part of a greater effort with all the molecular data that's being generated to really develop integrated biomarkers for detecting the presence of cancer, lung cancer in specific. And both adenocarcinoma and squamous cell are being studied.
Excellent. One thing maybe I missed it, but I think you mentioned there's 3 probes PET probes that you're looking at initially. What was the third one, if I heard that correctly?
So, we were just comparing in this particular study, FDG, which is the glucose, analog, and then FSPG. The third one that I mentioned was at the end, which is a glutamate analog. That's the next generation of that FSPG tracer that I showed you. And that we hope, could in the future, when it's being used in the clinic, give us higher signal and lower background.
I see. And do you have any other future directions that are planned? Are you going to add additional participants to this study? Are you still recruiting?
Yeah, from my understanding, we're still actively recruiting. The N is still quite small, so and then we're still waiting to also see the 2-year data. The study started a little less than 2 years ago, so we're only this year going to get to the 2-year mark on whether some of these nodules that we were trying to see if they were benign or not, actually, whether they stayed stable. So we'll have that data, starting, later this year, but we're definitely going to continue recruiting and getting the numbers up as well. And then we also want to correlate, as Alice was saying, with the molecular data. So, as we start to get the nasal swab data in and are able to do the DNA analysis, we might be able to kind of integrate those two together and see if a combination of, does something light up on FSPG, plus do we have, a molecular marker that's upregulated? And that combination might be more powerful than just having the PET alone or just having the clinical parameters by themselves.
Excellent. And I think the study's kind of already been proposed, but are you considering adding any additional measures, or do you have any measures that you wish you could add, knowing what you do now from starting the study? Kind of an open-ended question, but it's always kind of I know researchers always have a wish list, so I thought I would,
Yeah. So as far as I know, I don't know that our group has been considering other parameters, but obviously we're open to other parameters as well, whether they be, other imaging inputs or other molecular inputs as well. DNA has been a popular one, especially with, gene sequencing, but there's no reason why one couldn't add, protein biomarkers, RNA, circulating tumor cells, or basically any other kind of biomarker that you can think of to see how well this integrates with the imaging.